Great. So thank you all for having me. Just going to speak on radiation exposure and spine surgery today, a topic near and dear to my heart as I spend most of my days next to a radiation producing machine of some sort. I have no disclosures. Just a brief overview. We'll talk about history a little bit, a radiation exposure primer, just a little bit, getting some terminology, and then looking at sort of what's at stake, why is this an issue, some exposure studies, and then some modality specific studies. And then we'll talk a little bit about special populations. History of X-rays. William Röntgen discovered them in 1895 with some controversy involved, but notably this is a great image of his wife's hand, which was actually the first X-ray that he took and ended up submitting and obtaining the Nobel Prize for his work a few years later. This is actually one of his contemporaries and colleagues whom he sent his setup for the X-ray to, who then took pictures of everything and took X-rays of everything that he could find, including a frog with the eagle-eyed orthopedic surgeon may see the healing bone fracture on the left hind leg there. Amongst other X-rays taken at the time were incredibly long exposures of certain extremities in order to obtain as much detail as they could, including a 10-hour-long exposure of a hip, which then led to what you can expect after that much radiation to skin and an individual for that amount of time, terrible burns, terrible deformities, and really our first experiences with radiation exposure injuries. And so getting into this radiation terminology and units, the units radiation we use and all that stuff, it's complicated. I mean, we're talking about equivalent dose, effective dose, all those things. It's physics. They like to change the names of different units of measure all the time, and it can get to be quite complicated. The big part of understanding any studies that we do, why we wear the things that we wear, why these things are important, is just understanding that exposure itself, I don't know if you're able to see my cursor here or not, is the Röntgen, which we don't really use as much anymore, but really the absorbed dose. That's how much that you standing there, you're a patient standing there taking on the X-ray, that's how much you're absorbing. That's the gray value that we commonly will use. And then sieverts are the equivalent dose. And so that's how much you're actually seeing on your skin. And then your effective dose is sort of a measurement of your gray and your sieverts, and really a total evaluation of the total mean effective dose that the patient is then seeing. Really, the question is, who knows about this? Who cares about this? Why is this important? Of course, we all know X-rays are bad, and we have different modalities of utilizing X-rays within surgery. In this study that they did in Brazil, looking at 258 different surgeons, they gave a simple 15-question questionnaire asking questions such as, which tube on your eye in general emits more radiation? Is it the side that the attending stands on, or typically the assistant? You can pretty much guess which side. If you've ever had back pain associated with it, and then even simple things such as in hip fracture surgery, what's the right positioning of it in order to avoid as much radiation as you can. And shockingly, a high number of participants in the survey got a ton of these questions wrong. I mean, we're talking about 10.5% really knowing the period of risk to fetal gestation, 5.8 really only knowing the permissible radiation dose during those times, so likely because they're not operating on those patients, but less than half knowing safe positioning of the tube is really an issue when the surgeons themselves don't know. And it's not just restricted to Brazil, where similar outcomes were being seen in American populations. And so an interesting point was looking at the patients survey. And so not just us as the physicians, but our patients, did they feel like we discussed that their surgery would even involve radiation, or that they would need radiation for years to follow certain spine surgeries? Also looking at patients that have had spine surgery, did they discuss imaging use at all, or what that radiation exposure even means for them? And then looking at essentially guesstimates from patients, surgeons, and comparing those to the literature of what the dose estimates are and the effective radiation dose estimates are from different modalities. And so pretty shockingly / very important is the CT O-arm versus a CT traditional versus an X-ray radiograph, which I'll elucidate better, but later on with a different paper. But the CT O-arm actually shows about the patient estimates were about 7 gray. The surgeon estimates were about 60, and really you're seeing about 158. And so it's about 3 times off for surgeons, and, a massive amount off for patients of understanding just how much exposure they are getting with the CT and the O arm. And so what is at stake? And there's a nice little talk on Scoliosis Research Society looking into increased risks of thyroid cancer in their members. And so it was brought on by a few of their members actually coming down with thyroid cancer, including one of their acting presidents or former presidents. And in the survey, they had about 620 SRS members that they ended up analyzing. The types of cancers reported were varied along the track, but thyroid really sticking out. And amongst those numbers, actually found that there was a 23 times risk of getting thyroid cancer just by being a member of this incredibly small membership society involved with, obviously, high exposure to radiation. And so in getting into radiation exposure to the spine, there was a great study in 2000 that helped to classify why this is important for neurosurgery spine surgeons and really for orthopedic spine surgeons, given the breadth of exposures that you have to different methodologies. Rampersau's study showed that there was a 10 to 12 times greater rate of radiation exposure to orthopedic surgeons. And so I was able to see reasons for that, or orthopedic surgeons that are doing spine. And the reasons for that is the eye is so close to you with this scatter effect, and it really affects the uncovered sources. And so, yes, you wear your lead, yes, you wear your thyroid, some may even wear lead glasses, but given the proximity that the hand is to the eye, the groin, the axilla, the breast, areas that are not always covered, there's actually a massive amount of exposure. And so it's not just for our attendings, it's also for residents. And so there's actually a study looking at what the exposure to residents is in the modern era, and a nice graph showing what the effective dose in millisieverts is to the surgeon from a single exposure. So you can see an MIST left being about 0.02 an effective dose versus a CT of the head being about 2, and then a CT of the abdomen pelvis being about 10, and total cumulative 7 years of a neurosurgical residency actually being 12.15. And so these numbers are all good and well and good, but what do they actually mean? Why should any of us really care about these? And looking at our annual protective measures, basically looking at what the limit of radiation you can obtain without having negative effects throughout your life is. These are the numbers, looking at about 50,000 MRM and then maximum 5,000 a year. And so getting into sort of procedural studies and which methodologies we can even use, why we should even use one over the other. And so this is actually a really good study that helped us to see that key areas were being affected. So you have your thyroid, your chest, your hand, and really seeing really high levels of this. I wish my pointer was able to work, but high levels of this, seeing surgeons same side as source. The key part of this Marsicalco paper is that there's a 7.7 times increase in dosage just by standing close to the emitter side as opposed to the receiver side. And 5 steps to minimize exposure is going to be all the things that we now do. This is where a lot of our protocols came from, including monitoring annual exposure, wearing thyroid shields, lead glasses, lead aprons, using hands-off technique when using fluoroscopy, and then establishing radiation exposure in the OR during level localization, even using the mobile lead shields that we use commonly here in Maine, and then looking really at seeing who is standing and where they're standing on the side opposite to the X-ray source when using the fluoroscope. There's a great paper in 2013 by Tahir, who was a young investigator winner, but really showing areas that we think are protected, but really aren't. And seeing that, even though we may say these are, great, acceptable, as low as reasonably achievable guidelines for radiation safety, and we have these upper limits, that really achieving those is a little more difficult. And so the number that this paper is often quoted for is that you can perform 2,700 lateral lumbar interbody fusions within a year. But realistically, those are not going to be your only radiation sources that you receive throughout your life. And so in evaluating that closer, and this is really where their numbers come from their institution, but if a surgeon does more than 169, lateral procedures in a 3-month period, or 507 in a 3-month period, that is going to trigger, a pause warning. Also, that's an incredible number of lateral procedures to perform by any means. And so the numbers are really starting to get to evaluating how many procedures we can do and what our limits are with this radiation technology. And so just interesting little tidbits are random studies that have found small changes in morphology of surgeons, 35 years old, 46 years old, of dominant versus non-dominant hands, just because all of the surgeons at the facility were leaving their hands in near to receivers and seeing changes in that. Then also looking at a few different fields have looked at what the testicular radiation exposure is and whether or not offspring gender is affected by that. There's been studies in cardiac cath lab and radiology and also in orthopedics and various sources. And so getting to the meat of why we're here, being on a pediatric spine deformity and deformity rotation, there's sometimes a difference in beliefs of how to place screws, what is the most efficient way, what is the benefits timing wise, and what is the benefits to either the surgeon or to the patient. And so the question is radiation exposure. How is that affecting the surgeon and how is that affecting the patient? And so with fluoroscopy and with really the advent of minimally invasive spine surgery, there was a massive increase in the amount of radiation used in order to visualize all the tools being used. Unfortunately, that radiation is both expressed to the patient and also expressed to the surgeon itself. And so in looking at less invasive spine surgery, study came out back in 2014 showing that there was more accurate pedicle screw placement with CT and navigation, but in fluoro and fluoroscopy and 2D fluoroscopy, there was significantly higher dose in those cases. Excuse me, yeah. And this study was a little bit flawed, but saw that there was actually higher doses in the navigated case compared to the non-navigated. But in further studies, they then saw that the pedicle screw placement, looking at freehand versus fluoroscopy, did show that there was a much better accuracy with these CT navigated procedures, but fluoroscopy based worse. And very interestingly, the perforations would tend to be medial with freehand and lateral with the CT nav. And then looking at just really accuracy in our population of the pediatric spinal deformity, seeing 3 times as likely to be deemed acceptable, 2 times to be deemed as perfect, and then a third to be potentially unsafe with placement. So only a third is likely. And so again, accuracy is being hammered in with the CT nav. There's been many studies as well showing that CT navigation really takes the entire burden off of the surgeon. In comparison to a lateral procedure with a limit of 2,700 procedures, there's some studies showing up to 1 million said procedures with CT navigation, as the entire staff will often walk out of the room, avoid it, or even standing behind lead shields and avoiding the cone and the beam of radiation. Looking at radiation exposure and posterior lumbar fusion, there was a great study that really compared intraop fluoroscopy, CT guided navigation, and robotic assistance. And so really looking at all 3 of the commonly used navigation methodologies, whether it's 2D fluoroscopy, navigation true with robotic, or navigation true with CT. And it really illustrated well the issue at hand, where your X-ray with your fluoroscope is really affecting not only your patient, but due to the scatter, everyone in the room. And with typical setups of these robotic on the left and O-arm CT on the right, you're able to see staff is able to step away, is able to move away from the field as needed when either re-registration is needed or syncing with methodologies are useful. And then looking at the perioperative outcomes, the main point from this was that operative times, interestingly, for their navigated, CT navigated systems, was significantly longer than any other system. This was a study of about 165 patients, 1 to 2 level T-lifts. And so seeing a time of 303 minutes, or even 390 minutes for a 2-level T-lift with CT navigation, or 260 minutes with robotic. That's a quite long amount of time, and it makes you wonder where we were in our learning curve during these studies, and where optimization techniques and workflow techniques have decreased on time. And then really getting into the procedural radiation, seeing that a CT and an O-arm CT itself qualifies as about 85 fluoroscopy images. And so one O-arm CT qualifies as about 40 to 80% of a typical CT, especially now that we have low dose methods. And that's been used in explanations to use this methodology in pediatrics. But at the same time, in comparison to using an X-ray and the benefits from that, there is still a significant decrease in radiation exposure. And so it's a balance between who is seeing that radiation. Note as well, the robotic and MIS patients tended to have these pre-op CTs, and a measure that I'm a little critical of the literature in is that a lot of the CT navigated studies, especially the ones trying to advocate for the use in pediatrics, ignore the use of a pre-op CT within their workflow, and it really affects the numbers and affects the radiation exposure. And I've seen many studies actually be clearly affected by that issue and by not qualifying for that. So looking forward and seeing what is next, what is on the horizon, looking at either less invasive pediatric spinal deformity surgery. And so this was an interesting paper where the proposal was essentially using minimally invasive spine techniques due to the relative flexibility of younger spines and the propensity of bone to heal and fuse. And so being able to avoid as much muscular detachment as possible, and then using these new technologies in order to place screws. In this study, they used specifically robotic assistment, but they also used 3D fluoroscopy intraop. They did have pre-op CTs and also had a C-arm available as well. And so almost entirely ignoring radiation exposure with that argument, and with saying that this would be a useful advent for the future. Additionally, looking at the accuracy of pedicle screw placement, study after study with CT nav and with robotics shows that there really is an improvement. There really is a use for it there. And so being able to avoid needing to revise screws, being able to avoid having an unfortunate breach, does see significant benefits from it. And then also looking at just the history of it in spinal robotics is just taking off just the amount of time that is being spent and the opportunities that they've had to use these in patients. And so studies are actively taking off. And the big question is, why are we doing these? Why does MIS work? And I don't want to get an argument of, MIS versus open, but we're entering an age where this CT and this X-ray navigation and techniques will really benefit us in being able to approach patients, not just through an ALIF, but through single position procedures. And looking at just the advent of studies, books, textbooks coming out about minimally invasive, and now even moving into single position techniques, looking at, like I was saying, lateral interbodies and percutaneous pedicle screws posteriorly, all in a single position. We're starting to see more and more studies show that the patients can either tolerate this better, that it decreases burden on hospitals and burden on patients, but I'm sure we'll see a swing back in the other direction as well. This is just an example of one place that actually does that simultaneously with one procedure, or one surgeon doing the lateral and one surgeon preparing for the posterior percutaneous setup. Pretty common setup to what we will use here as well when performing that. And then looking at some new technologies and sort of what's on the horizon, there's a plethora of devices coming out. Really, some new technologies are older technologies, which are sort of hand-based basic navigation tools that can use either a single fluoroscope shot or another fluoroscope shot. There's actually a study that demonstrated simply making without even using a fluoroscope, palpating and inserting a probe, and then sticking your finger down and being able to palpate in between the muscles and feel your spinous process and your lamina. And then using that, they then placed K-wires and placed screws and took an X-ray afterwards and evaluated their outcomes. I hesitate to not recommend that, but to say that that may be going in the wrong direction technology-wise versus looking at new opportunities in the technology literature sphere, as well as looking at really ultrasound, which has been a pretty shocking thing. I never would have thought ultrasound would really be useful for screws, but there's an active group that has been looking for years at using ultrasounds in order to evaluate both in the clinic for adolescent idiopathic scoliosis, and now is actually as a proof of concept model looking at 3D ultrasound, being able to place screws, and has opportunities significantly for being able to use that as a real-time monitor. Additional opportunities for future real-time monitoring within the OR is these machine vision systems that are coming out now as well. Really comparing them to just basic pedicle screws at this point, because they likely aren't at the point of being able to compare with CT navigated or robotic navigated, but essentially allowing for decreased radiation exposure, really no radiation time at all within the operating room, and then showing similar now outcomes to CT guided screws. And then really at the end of the day, whatever tool we're using, whatever we are planning to use, just make sure that we're optimizing what we do have available. The key principles that trying to instill from this talk are just that we need to wear the safety gear that we were given. We need to really respect the radiation exposure limits due to just the amount of cancer and the increase in amount of cancer that we do see throughout a long career within spine. And so this is a study from back in 2005 that even shows that the lead aprons that we wear, that we buy, may not actually be up to snuff, and actually demonstrated one significant outlier amongst different brands of lead aprons that was definitely letting in too much X-ray. And so whatever technology we adopt, it's really going to be up to us to optimize that and make sure that we are using that usefully and critically evaluating that material. All right. So a special thank you to Dr. Corrick, Dr. Kim, and to Dr. Bowl, as I've been on this deformity rotation and really thinking critically about how much radiation we are seeing and that we are delivering both to our patients, but then also to ourselves and our staff around us. Thank you. Any questions?
Graham, thanks for a great talk. Let me ask you, with some of the three-dimensional imaging techniques we have, we have a lot of interest in getting some of the new fluoro units. Is there a consideration there that may be different than what we're currently using?
Sorry, I missed which technology you said. You cut out. You said 3D, which units?
Yeah, there's some 3D fluoro units that our trauma team is considering, and I think they could also be used for spine. But wondering if you have any experience with those particular, perhaps more modern units.
Yeah, we actually don't use 3D fluoroscopy as much in our spine work here. There's a good amount of papers on it, and last time I gave a MSKI grand rounds, I think I misunderstood the timing and gave about an hour-long talk instead of a 20-minute talk. And so I do have a lot of studies looking at the 3D fluoroscopy. It's showing similar rates to CT navigation and to robotic navigation of accuracy improvements, but does have the increased radiation exposure. I think there's a great modality that is improving, but they're all kind of neck and neck in the race for me on which one is going to be the most useful in the future.
Hey,
Thanks,
Graham.
This is John. Oh, go ahead.
Sorry.
Go ahead.
Quick question. So you were mentioning kind of a comparison between the navigation and then just regular fluoroscopy. It seemed to me that for the surgeon, at least, mostly like I'll see surgeons leave the room during the O-arm spin and then come back and do the case with navigation. So it seems like it would be a drastic reduction in radiation exposure to the surgeons. Obviously, not for the patient. But is that a reason to favor it from a surgeon standpoint?
Yeah, thank you for that question. I think that's really at the heart of my talk. I took out a slide that I kind of wanted to keep in. It seemed controversial, but it's the question of who matters most in that situation. What is the actuarial risk of exposure of radiation for, a few surgeries in a patient's lifetime versus surgery every single day for a surgeon and the staff around them. And so for CT and O-arm and for and intraoperative CT, it has great benefits for being able to essentially make it a null effect of radiation exposure to the surgeon and the team, but it really does increase the amount of exposure to the patient. And so in thinking of opportunities where CT navigation versus just basic freehands really has or freehand techniques really has the best benefit, is going to be in deformity cases or abnormal anatomy or multi-level fusions versus, one or two level interbody fusions, which has been used in these studies. And so really a lot of the studies have looked really at accuracy of placement as the main utility, as the radiation exposure benefit is pretty noticeable. to the staff, but high to the team. And so really remembering that a CT is worth about 85 X-rays and can increase your radiation exposure to the patient in a case of by about 5 times as much.
Yeah, Graham, I think Samuel's comments are very important. I think you mentioned the exposure to a pregnant patient, but we also have pregnant surgeons, pregnant OR techs. So the exposure in that occupational space is very important. I was glad you sort of mentioned at the end there a little bit about, lightweight lead, because that's an issue. Certainly all the technologies we use to decrease the amount of X-ray generated is important, but we have to remember that the most basic level, the best thing we can do is to protect ourselves from the radiation that is produced. I put in the chat a paper that we published looking at just exposures and education and availability. The biggest barrier to proper use of lead was unavailability of lead. So our program has, for almost 15 years now, provided lead to the residents. We have lead glasses, another huge exposure, which I think was also in that Ted Wagner study from SRS. I was actually Ted Wagner's fellow when he published that paper, so I know the paper fairly well, that survey he did with SRS. But I think that we have to all the things that we can do, proper use of leaded glasses, thyroid shields, circumferential lead, those things are all incredibly important to us, because as you just said, in response to Samuel's question, the fact that a patient gets a little less exposure to radiation is all well and good. And we can talk about, a child is more prone to, long-term consequences of radiation based on the CT data in children. But really, we are the ones who probably need to be protected most, not just surgeons, but every person in the operating room. So, really understanding the how we generate radiation and how we can protect ourselves is super important. So thanks for helping shed some light on this important occupational exposure topic.
All right. Thank you for having me.
Great. Thanks to everybody. And we'll look forward to seeing everybody in person next week.